New York State Athletic Commission Medical Advisory Board meeting to order. It's now about 6:19, and I want to acknowledge that we do have a quorum present. The first order of business will be the minutes from January 6th, 2016. Did everyone have a chance to review the minutes? Any questions or comments, corrections?
I thought they were complete.
Okay.
And the only thing I noticed was some of the comments that were attributed to me, they're much more specific in the minutes and much more accurate than whatever I said. But it was, part of it was just trying to make sure that there was adequate indemnification protection, but it went into like which section of the law, and clearly I didn't know what that was. I'm okay with that being attributed to me.
So can we get a motion to accept the minutes?
Motion.
Second. All in favor? Okay, good. So let it be noted that the Medical Advisory Board minutes from January 6, 2016 were unanimously accepted. The next order of business is to review the applications of panel positions. For the personal and confidential nature of this material, we need to go into executive session. out of executive session and the medical charts of Dr. Thomas O'Brien, Dr. Nicholas Beatty, and Dr. Joseph Sylvester were reviewed by the MAB. And I'd like to have a nomination.
Make a motion to approve all three.
Second. All in favor? Okay. And there was one exception with Dr. O'Brien, that he had to provide his current license in order to be approved. The next order of business is discussion of the drug acknowledgement form. Did everyone get the opportunity to look at the drug acknowledgement form? Basically, this is to be given to the boxers when they come in. Does everyone have a copy of it? Yeah. Does anyone have any comments or thoughts regarding the form?
The only thing I might do is maybe bold the part that says, in addition, boxers are not to use any drugs, medications, and supplements, just because it kind of blends in with the first paragraph, the last sentence, you know, just to make it stand out more. Because that has the part with the supplements, and they're not all listed otherwise.
The way you see it, where you
No, I was saying that maybe that last sentence, I would probably bold it, you know, to make it more, so you could see it more clearly. About the, in addition, boxers are not to use any drugs, medications, and supplements, between, like, make that in bold so that they, you know,
right.
more emphasis for that one, I think.
Okay.
I take it the list of PEDs, is that either what we had before or the same ones that Dr. Verlotta provided? That's the one and the same?
These are probably ones we had before.
As far as process, I mean, the blood is drawn in advance of the fight. I mean, are the results, or urine rather, are the results back at the time of the fight, or is it? I didn't think so. I mean, that's a huge list. It's got to be days or weeks later, right?
It's about a week later. Getting back.
So, I mean, I guess that there's a potential impact on the fight outcome, but we wouldn't know, or the opponent wouldn't know about it until a week after the fight. Is that right?
And traditionally, what happens if they won their fight or won a title, they would actually be suspended, and they would actually lose the title, lose the fight. If it's a performance enhancing drug. Any other comments about the form?
We had discussed the topicals. Was that?
So you should include.
It was specifically, we were not trying to invoke the topical diclofenac, I think.
Yeah, the Voltaren.
Right.
Yeah.
But there's these topical testosterone gels too.
Yeah, right.
But those are more systemically absorbed. I think the topical diclofenac is more locally, right? Because it wasn't so much that these were necessarily performance enhancements, but
Bleeding.
right, there's a bleeding risk to this. Right, so I think it was that the topical diclofenac, I think what we discussed before, was not thought to be, was not thought to interfere with platelet function, right?
You're saying that there should be a note that topical nonsteroidals are allowed?
I would add it on the diclofenac there, just say other than topical, because I think that's probably the only one there.
What's in the Flector patch?
Same thing, right?
Is it diclofenac?
No. Is it?
I'll tell you in a minute.
Yeah.
Yeah, it's diclofenac and apolamine. Topical.
Okay. So we'll just put add a note that topical diclofenac is allowed. That's correct? Sounds good.
Are we making a note anywhere in here that this might not be an exhaustive list? I mean, something new comes to market on this list.
Yeah, this came up when we were talking about herbals as well.
Yeah.
Yeah.
I mean, the one slippery slope you start getting into with topical diclofenac is, somebody may want to take a bath in it, and then, the typical pharmacokinetics we think about may actually be less, quite similar to the oral preparation. If somebody's using I think there are case reports of people using, was it topical aspirin cream? Does aspirin cream have aspirin in it? And people are having hemorrhagic complications from that. But it's, these are people who are putting it on like 40% of their body chronically. Maybe we just leave it as is, just so that abuse potential doesn't come through. It's not even abuse, it's the bleeding risk.
Right.
So disallow topicals, you're saying?
Yeah, just because, the typical way that we think about it is a flector patch is,
Yeah.
small and there's a little amount of salve that's put on there, but, somebody may take it, douse their arm and their leg and both legs, and then you have a very different problem.
I wouldn't say it's impossible. So, okay, so then we'll leave it as is?
Maybe we should.
Okay. With the caveat of just bolding the area.
Because it's probably, if they're using it appropriately, it's probably not even gonna, it's like 15% absorption, something like that.
But again, the presumption is it's a small area over a single joint.
They don't test them for non-steroidals.
No.
Yeah.
No. We did have one situation where one of the boxers used a non-steroidal after the weigh-in and before the boxing match. And the boxer was honest about it, but we did not allow the boxer to compete. So that's why we also added this in this acknowledgement form that you should not take any medications between the weigh-in and before you compete. They weren't aware of that. So I guess we could vote on this. So a motion to accept the acknowledgement form
Yes, so many.
with the recommended changes in terms of bolding some of the type. Second. All in favor?
Aye.
Okay, let it be noted that the boxer acknowledgement form for drugs was unanimously approved. And also included, we sent around the, this is just a bulletin. For the commission. Everybody get a copy of this, or?
Which one is it?
In your handouts that was sent to you was the last page, but this is actually a separate bulletin.
Yeah.
Jim, could you just elaborate on how the bulletin works, so that?
Oh, sure. The bulletins are, it's a form that the commission uses for official notice to licensees. So that's just the term that's used in the rules for communicating an official notice of something. So over time, the State Athletic Commission, when it meets as a body, might vote to approve a bulletin and then send out an official notice to licensees about a variety of topics. They just caption them consecutively based on the year and the number that the bulletin is, and it addresses some topic of import to the boxing community, or to introduce a new policy that they're going to enforce, after some date. So I think this is, a draft, no guarantee of the commission's acceptance of it, but it was a draft that was prepared think along with this, with the idea for the acknowledgement form, to provide an additional form of notice to the boxing community. So I imagine, the discussion here would be to look over the language and to see if it seems appropriate or if there's anything that should be suggested for change, and then based on your recommendations, commission staff will go back, look at it again, and then prepare something for consideration by the commission. So, is it?
I mean, what's the mechanism for approving a drug? The example Dr. Barlotta gave was that there was a high-profile tennis match at Wimbledon where the player took a prednisone tab, I think, in advance of the play because of it was prescribed for a sinus infection. So there had to be, some sort of emergency meeting. I don't think we really have the mechanism in place for a quorum to be established, but is it just at the discretion of you, or?
It's basically it's at the discretion of the medical department, and it's usually done at the time of the weigh-in when they're being examined. And depending on the medication, whether it puts the boxer at an advantage or disadvantage, then consideration will be made according to that. Doesn't happen that often, though. So, any comments on the bulletin?
Looks fine.
Okay. So, can get a motion to accept this?
Can I ask one thing, just to draw attention? Now, there's an effective date written into this draft that says it's effective immediately, but applicable to all boxing events not previously approved. Does that make sense here? Would something like this basically be rolling out for, whatever scheduled event after the commission would?
Makes more sense to,
just say it's effective immediately upon issuance by the commission, or does it make sense to, because Eric, the event approvals, you approve events sometimes. You might have an event approved that's a month from now,
right,
or 2 months from now. So should we maybe modify that effective date to just say effective immediately, which would be upon commission issuance? Then we'd send it out.
Yeah, I suspect there's more of a legal issue why that was put in there, though. Correct, you think? Because what's being implemented.
We've been using a form like this for the last 7-8 months, probably, right?
At least.
Right.
Yeah.
And so I would think that any modification of the bulletin could just go out immediately. Yeah, that's all I'm saying is I think, this draft, I'm just noticing now it's got a.
So you don't think that bottom part is necessary?
No, because I don't think that we're changing any
right.
condition for a boxer, because really the boxer had, until that weigh-in and that physical examination occurs, they're not even, at this point, they're not even fully licensed yet, and they haven't been evaluated, and everything that this relates to is a notice that's for their license and for their determination of fitness to fight and affecting the events from, the physician examination at weigh-in to the time of the competition.
Right.
So, I think you could make it effective immediately, and I don't think it has to muddy the waters by saying, well, what has or has not been approved yet internally for future event dates.
What fundamentally is different about this? Is it just the NSAID policy, or are there new PEDs that are listed?
Well, in the original form we have, the PEDs aren't even listed. It was just more of an acknowledgement that NSAIDs put you at a greater risk of bleeding. Now this is actually prohibiting you from taking them the week before, and it's actually listing each of the drugs for the PEDs that you shouldn't be taking.
And that was not previously provided?
It was provided on a separate list. It was never combined on the same list.
Yeah, so they had notice of the PEDs. That's already been out there.
Yeah.
The biggest thing is I think the instruction about, putting in writing in a notice beforehand an instruction about not taking any substances between the weigh-in and the event, because I don't know anywhere that, other than in instructions given in person, maybe at a weigh-in or at a physical exam,
Yeah.
where that's been put in put up front in a notice.
I don't think it would derail a fight, say, happening on Friday either, right? These are not permanent COX-2 inhibitors that we're talking about, right? So, I mean, the function of the drug would be a moot point as soon as it's stopped, within 2 or 3 half-lives, right? My point is, if you put this into policy today, which was not in policy earlier today, and you have a fight on Friday, would some boxer all of a sudden not be allowed to fight?
This has been in policy already. This is just a bulletin
Yeah,
acknowledging the policy for the boxers to give. Is that the proper way to say it?
Yeah, but I would say the real new addition is the language that you suggest to be bolded, which is the instruction, hey, look, don't take anything that's a supplement, a medication over the counter, or prescribed, unless you first contact a clinician, speak to a physician, and they are allowed to consider what this thing is. Because we don't want that instance where somebody shows up and then right before a fight says, oh yeah, this morning I had a headache and I took blah, 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 blah. And they didn't check with anybody, and it renders them disqualified. So we want to make sure that we're giving clear notice about that.
That has happened. That has happened twice actually. Now that I think about it.
Okay.
One where the urine came back after the fight, and illegal substance was detected in the urine, and that boxer ended up being suspended. So.
Right.
Okay, so I think the verbiage at the bottom you said would just remove and say effective immediately.
I would just leave it with effective immediately.
Okay, this policy shall be effective immediately and applicable to all boxing events not previously approved by the commission. What does that mean exactly? Not previously approved.
That's what I meant, but that's the language that I thought was confusing, and so I would just end it with effective immediately, period.
Why not say currently scheduled and forthcoming events? That would include every event then.
Say that again?
Why not say that this policy is effective immediately and applies to all currently scheduled and future events? That way, I think the issue is that if you implement it now, would it apply to an event that was already set up that had a different set of rules fundamentally when it was set up? I don't think it fundamentally is that much different than what you had before.
It's not. It wouldn't make a major difference. All promoters have been having the fighters submit this with their contracts, actually. So, I don't think it would make it. I mean, if you want to add the language, I'm sure it's fine. But I don't think there'll be any issues for any promoters moving forward to just honor the policy that you guys.
I mean, the only thing that maybe you could do just to kind of double cross your T's would be to contact any promoter for a fight happening, tomorrow or Friday.
Mm-hmm.
Just say, look, hey, heads up, this is what's happening. Just make sure your boxer doesn't take any drug on this list or the NSAID list at least today.
Yeah,
you should be fine.
Yeah, and I would point out this really doesn't change. Like, let's say there's an event coming up Friday. They've already been given notice of that, of the NSAIDs. They have notice of the performance-enhancing drugs. So the only thing that this would do differently is basically just upgrade the one form to put it all in one more spot together, but add the caveat about between weigh-in and event don't take anything. No weigh-ins have taken place yet. So, being effective immediately.
And the doctors actually instruct the fighters at the weigh-in too.
Condition of the promoter's promotion or anything by this. It's just an additional form of notice. So I think we can just say effective immediately, and that covers everything. Although I agree, your suggestion is fine. Do that language is fine. It's just the way it is here. It says and applicable to all boxing events not previously approved by the commission. So I thought that doesn't make really much sense in the context of what we're trying to do with this.
Okay, so motion to accept this commission bulletin with the change at the end that the policy shall be effective immediately. We have a motion to accept it.
So moved.
Second.
Yes.
All in favor? Okay. Let it be noted that the acceptance of this commission bulletin was unanimously approved. The next order of business is to discuss the updated ringside physician protocol. And basically what we did here, we made a few changes, which are the changes that are bolded in the duties of the ringside physician. The additional reason for updating this protocol is also to have a job description for the ringside physicians who will become employees of the state. So we needed some type of job description for them, since they're going to be employees. So this basically outlines the duties of the ringside physician. Parts of it are rather detailed, actually, for I think for a job description, but I don't think it's overly detailed. In particular, in the area where we talk about intra-bout duties, if we have 3 physicians present or 4 physicians present. But I think it still leaves room for some flexibility in terms of the functions of the ringside physician. Does anyone have any comments at all, or any thoughts about any changes about this protocol?
I thought it was very thorough.
Okay, so do we have a motion to accept the updated ringside physician protocol?
The only thing that I was thinking about, I think after the last meeting that we had, there was a big article that came out in the Times that it was about a fighter that was injured, and there was you probably remember it. I mean, this was back in January, right? Front page article in the Times.
In which state?
It was in New York Times. Yeah, it was about boxing, and there was one of the points that they brought out was about the timing of the post-fight evaluation. Is that clear as a job description when the post-bout evaluation is supposed to take place?
Yes, it is. And if you show exactly. Okay, if you look at post-bout duties.
Yeah.
And it talks about after determination about the physician is responsible for identifying any injuries and no medical problems. The post-bout examination should assess neurological, musculoskeletal, oculofacial, and other potential injuries. While the boxer can be checked at ringside after determination about the final medical clearance is performed in the locker room. So they have to be examined before they can even collect their money, and they have to be basically signed out as being medically cleared.
That article, was that the one where the guy, he died, right?
No, there was a guy, he was up in Connecticut and he was injured. I mean, it caught my attention because Dr. Barlotta was heavily featured in it. And he was here the night before giving us that presentation.
Oh, I thought I saw someone.
It was a big spread.
Well, I would like to mention that we probably should not discuss too much of that.
No, I
It's
don't.
an ongoing case.
I don't intend to. My point of discussing that was that I think we should be clear about what are the expectations of the ringside physician, including the timing of the evaluations. If the locker room is clear, I mean, I'm not a ringside physician, but if it's clear to you as a ringside physician what the timing of that means, but some of these applicants we have coming in are relatively new to the field, it might be nice to say that, your duties are officially over, 30 minutes, 60 minutes, 90 minutes after the bout is over. Once the evaluation has passed, I mean.
Well, we have, if you look, let me see. In terms of when their duties end, if you look at number 16 on the post-bout duties, the ambulance and the physician are to remain until the last boxer leaves the locker room. So their duties continue through the time the last boxer leaves the locker room.
What would be a normal time frame for that?
Depends on what what time that bout had occurred.
Let's say it's the last bout.
How long might that be?
Half hour?
If they have to collect the urine, they could be there for another hour or so.
Okay.
But my point is that maybe we should make it so that it's no shorter than, say, if everybody's in a rush to get out the door, you want to make sure that there's been proper time for the assessment to be done, so that it's not as though the physician's holding up everybody. Make a bit more specified that it doesn't happen any sooner than blank.
Yeah, but it has to. Yeah, but the thing is that it's kind of tricky because another way of looking at it is that you want the evaluation to be soon as possible as opposed to later.
Right.
So I think to have a specified time, I'm not sure if.
Well, the reason I bring it up, I mean, there's some, I mean, that from a facial injury standpoint, those are going to be pretty obvious and immediate, but some neurological, epidurals may take a little bit of time to collect, for instance, or a subdural may take a little bit of time to become symptomatic.
Right. So, I mean, what we do at the fights is that if there's a boxer that there are some concerns about, we don't clear them right away. Sometimes we'll have them get dressed, wait in the locker room for a while, then they're reevaluated. That's not uncommon at all.
I mean, but that sounds like something that's second nature for you with a lot of experience. But for the younger person, maybe that's something worth putting down for them. Mm-hmm. It's up to the physician's discretion to take perhaps a longer time for assessment than somebody who has concern raised about a more serious injury, neurological injury.
Okay, so says here on number 4 on the post about duty, no boxer is to receive monies for competing until the physician medically clears the boxer. If the physician does not immediately clear the boxer post-bout or orders additional treatment until the boxer agrees to appropriate treatment and follow as ordered by the physician.
Thank you.
I don't know, how would you want to word that? Or, because to a certain extent we have to leave it, to the clinical discretion of the physician.
I mean, if you look at number 13, it kind of, I feel like it's sort of addressed, because it says the medical responsibility ends when the physician medically clears the boxer. So it's kind of leaving it up to the doctor, right? So if the doctor says, I don't feel comfortable, wait a little while, So I feel like that kind of covers it, I think.
Okay.
And number 14. It was cleared and then is feeling dizzy or double vision or.
Yeah. There was number 14. I think that pretty much covers it too.
Yeah.
Is it the case that sometimes boxers will have a later appearing symptom that they don't disclose to the physician? They disclose it to their trainer.
That's always a theoretical possibility. Yeah. But again, it also depends on what type of injury you're talking about too. Certain types of injuries they're more likely to conceal as opposed to others. I think that the way it's written here covers those issues that you raised.
Okay. I agree. I don't think we want to make it necessarily too prescriptive. We leave it open to the physician discretion. But.
Right. Okay, so can we get a motion to accept the physician ringside protocol?
Yes, so made.
Second. All in favor? Okay, let it be noted that the ringside physician protocol was unanimously approved. Okay. Now, next order of business is any discussion about new business or having open discussion. One of the issues that came up recently, I wanted to bring it to the attention of the Medical Advisory Board, was the concern regarding examination of referees. This issue came up recently. As it stands currently, annually, referees are required to get a physical exam from their physician. They also do an electrocardiogram, and we also have an eye examination by an ophthalmologist or optometrist. That's pretty much what we do currently. The question was raised, should we be doing examinations on referees pre-bout? My clinical opinion was that it probably wasn't necessary, but I wanted to bring it to the medical advisory board for any comments.
I think the football team I cover, the referees come over with a manila envelope that's never opened that has all of their past medical history, and it's kept by the physician on the sideline in case any of them go down. So you can open it up and see if they have a past medical history, but otherwise it's never opened, which would be of some value perhaps. If the guy passes out and he has a defibrillator in, or he's diabetic or something, and it's actually helpful, and they do it routinely now. Part of the thing, they just bring it over, and it's never opened, and it's given right back, and it's never opened.
We usually have the medical records of the referees on file. Not at the.
But are they available if the guy drops?
Probably. I think if the guy drops, you'd probably be more worried about resuscitating him and getting him to the hospital. But
That's nice to know if he's a type 1 diabetic or whatever.
Mm-hmm.
Any other comments?
If you have those records on file,
they get hit too.
Right.
why can't it be known, to the ringside physician that he does have a problem?
Yeah, most of them don't have problems though. But I mean, yeah.
Well, I mean, something of this magnitude,
I
you guy may have a defibrillator.
I remember what we used to do in the amateurs. That before we would have an amateur competition. The ringside docs would examine, just do a vital signs on the referee, do blood pressure. Do a real brief examination. But unless somebody's really sick, evaluating them right before they get into the ring, I'm not sure how that is going to prevent anything.
And then the other thing is, I think these guys, they are exercising. They're also in the line of fire. They sometimes catch punches, right? But then the other thing is, where does that end? Does the ringside physician then need to be evaluated, for their own health? I mean, where does it end? How long does the string go out? It seems a little excessive.
Yeah.
So do we sanction the officials?
We license them. Yeah, so to get their license, they have to have that medical.
Yeah, I think that industry standard is not to do a new physical exam like the NFL physician, they have to submit their yearly annual exam, but they don't, every game they don't get re-examined.
Yeah.
So they're fit for duty in general.
Yeah, there's no professional sport that.
Yeah.
Will we license a ringside official that has a defibrillator?
I have not as of yet. I haven't seen that yet.
Okay, or any other serious medical problems?
Yeah, we haven't had any that had any serious medical problems. But I remember, again, this is in the amateurs, there was a referee that used to pop nitroglycerin between rounds. Which I thought was amazing, but yeah.
All right, have we ever rejected an official because of a medical problem?
No. No. The only ones that have more medical problems are the judges, but they're sitting down, they're not really exerting themselves. So that might be more of an issue with a judge, but in terms of referees, majority of them are in good health actually.
I think that annually they need to submit a physical, but on a bout-to-bout basis, I think that's getting a little crazy.
So Yeah, that was my thought. So I thought I'd just bring it up to it may be for discussion. Okay, that was worthwhile.
Maybe the point to put in the minutes is that anybody who has a sudden collapse event of whatever cause, they're going to be given the ABCs, typical assessment anyways, and whether or not they're diabetic or not, that's going to be assessed, right?
Yeah.
I don't think that's the issue. I think the issue is if they have a pre-existing medical problem, then the referees in every sport have to be almost as good of an athlete as the competitor.
Yeah.
So that's something that we should be aware of, and I think that's where you were going with that, right?
So,
yeah.
so each year I review the medical exams of all the referees and the judges. So if there's a medical problem, then we'll deal with it. Mm-hmm. So, and then we've had, I've had some even evaluated by cardiologists in the past, if I recall correctly.
Is there there's not a backup referee there?
Oh yeah, there's always a one-on-one referee.
Mm-hmm.
Yeah.
How many matches does a referee do? Like,
It could be anywhere, like it could be for one in one night, or it could be like 3 or 4 in a night.
Oh, okay.
It's highly variable.
It's pretty regular.
Yeah. Okay, so talking about emergency medicine and emergency preparedness, someone collapses. One of the things I wanted to bring forward, and Dr. Kinderneck would know what I'm speaking about. I guess a couple of weeks ago we had emergency preparedness with the New York Giants, and the company that did it was the Sports Medicine Concepts. And I was contemplating on whether we should have them do a in-service with our ringside physicians on how to do the ABCs of emergency care with a boxer in the ring, how to get the boxer out of the ring, how to do the log roll with them, how to get them on the spine board, how to get them into the ambulance. I know when we did it with the football, I thought it was very informative. I thought it was great experience. And plus, it's important to practice these things, because if you don't practice, and when something happens, you need to be fluid in terms of what you're doing.
Is an active ACLS certification required of any ringside physician?
It hasn't been. It hasn't been. No, it hasn't been. Do you have any thoughts on?
Yeah, no, I think we do it yearly, and so this program is very well done in the sense that he usually brings up some new ideas and controversial ideas, and in terms of for a little bit for the football, a lot of it's dealing with equipment removal and things like that, and then it's an active discussion to say, okay, we're going to do it this way, and so it isn't this one size fits all, but it really is an opportunity to discuss it as a group, and okay, how are we going to do this? And then there is some discussion in terms of role delineation. What came out of this year, for example, is that there's going to be an emphasis on somewhat of a medical timeout before to say, okay, who's going to call, who's going to do this, who's going to do that in terms of role delineation at each event. So I think it's really important that concept I would encourage, because when you're at these events and you're with different ringside every time and what have you, I think there is this kind of fire drill type of thing, and out of this we'll come up. This year we came up with a written protocol. So it's just basically coming up with protocols and practicing, and it's in a very practical way with mannequins and role delineation.
Yeah. I thought it was very good. And what's interesting is that each sport is a little different how you manage these issues, and you don't have to worry about equipment removal in the boxer, but there's other issues about taking the gloves off. Do you take the gloves off or not? Intubating in the ring or not? Things like that. So I think an exercise like this would be extremely valuable for ringside docs, especially considering that mixed martial arts might be starting, well, will be starting. So everyone think that's a great idea?
What was the name of the company?
Sports Medicine Concepts.
And they go around the country. They go to a lot of the NFL teams, a lot of NHL teams, and they're very professional in the way they present it. And
they're very good. They were excellent.
They're athletic trainers.
Athletic trainers.
Yeah. But the people that we had there, there were trainers, there was doctors. We had NFL games. They have the airway doctors, the anesthesiologists that do intubation. So they were there also. So it was a whole team effort. Okay. The other issue I wanted to discuss, we have a criteria for what we call high-risk boxers. Basically, these are boxers that we consider at high risk of medical injury, or in particular, for the most part, neurological injury. Currently, what we have as criteria for high-risk boxer would be a boxer who has 3 consecutive losses by KO or TKO, 6 consecutive losses by any means, boxers over the age of 40, boxers that have been inactive for a long period of time. Although we haven't really delineated a particular time period, but
1 year.
Generally we do it about a year. If you haven't boxed in a year, we put you in a high risk category. And what that means is that we may subject that boxer to more detailed testing. Most of the time, it's out of concern for chronic brain injury. That's the reason why we do it. The other thing is that we've been also looking at their records. So if they're poor performers, we would also put them in a high risk category. The only concern that I have is that determining if a boxer is a poor performer is rather subjective, as opposed to we have no objective means. So one of the things I was thinking about is whether we would have a criteria for any boxer who had more than 10 losses be considered a poor performer.
10 or more, right?
Huh?
It's 10 or more.
10 or more losses be a poor performer. That number is not totally arbitrary. We have done some studies in the past where we have noticed that boxers who had 10 or more losses were more likely to have progressive changes on CT scan. So there's a reasonable medical explanation to put them in the high risk category. So I want to just propose that to the MAB, get any comments on that.
Where does total and number of bouts fit in?
Again, that needs to be concluded some kind of way too. But the issue is, it's not necessarily the total number of fights all the time, but really the losses really makes the difference, I think.
So Barry, talk me through, so if somebody's identified as a high risk,
Right.
what then transpires?
Well, okay, let me tell you how it has evolved. In the periods where we used to do CAT scans, if they fell into the high risk category, we would get MRI scans. Now we get MRI scans on everyone, so we're looking into other types of evaluations. What I've been doing most recently is that I will have them undergo neuropsychological testing. And if that picked up anything abnormal, then I might do more testing along those lines. We have gotten FDG PET scans on some of our boxes. There's glucose PET scans and how the brain metabolizes glucose. And I've also had the opportunity, I was able to get amyloid PET scans on some of our boxes that are high risk. With the thought that if a boxer was a poor performer and had some mild cognitive issues and then had amyloid in the brain, I think that'd be a good reason not to allow them to continue. For those of y'all, the non-neurologists, probably most of y'all know anyway, amyloid is one of the major proteins in the brain that's deposited in individuals that have Alzheimer's disease or prodromal Alzheimer's disease.
So the idea being that somebody who has biomarker evidence of Alzheimer's disease should not be getting hit.
Right in the head.
Not to say that the amyloid is being caused by the boxing itself, but
No, I'm not saying that.
Right,
Yeah.
right.
Which is the whole other debate in and of
Right.
itself. Yeah. So, so one of the things I wanted to include was 10 or more losses to put somebody in the high risk category. And, in terms of total, number of bouts, I'm not sure,
I mean, the reason I ask is because, the way, at least there have been some in the football field that have been arguing for a hit count.
Yeah.
And you get hit, certainly even in a winning bout, but certainly it seems like you get hit harder and more severely in a losing bout.
Right.
And then the other thing to keep in mind is, do we have the same standards for different weight classes? I mean, simply the force behind a heavyweight punch is much different than the one of a flyweight.
Yeah. But as far as I can recall, in terms of chronic brain injury that we see in boxing, weight class probably does not change the risk. I think they're all at risk. When you look at it this way, the heavyweights probably hit harder, but they don't hit as often.
Mm-hmm.
The lighter weights, they throw a lot more punches. So
Do they fight more often too?
I don't know. They might, but I don't know.
It's all relative.
Yeah. So the other thing about using the total number of matches or bouts is that, if you have a boxer who's 45-0 and knocks everybody out in the first or second round, just by the fact they had 45 fights doesn't mean that they're going to have yet increased risk.
I suppose you also might have people who have very few bouts in their history but have been sparring partners
Yeah.
in a less obvious way just as long.
Yeah. So, like I said, up until now, we've been pretty much subjectively looking at their records. And obviously, if a boxer comes in and has 12 wins and 30 losses, obviously that's a poor performer, and they would be subjected to more detailed testing. The other reason why I think I'm really a proponent of this is that I think it will also discourage using boxers that lose all the time. That's something I have a major concern about. Having these boxers come in at 20 losses, 30 losses, they haven't won a fight in 5 years. So I just want trying to avoid that from happening.
If they have 20 losses, haven't won in 5 years, I'm not approving them. Don't worry.
Yeah, but I mean, I think the point's well made is, I think as a commission, we don't want people that are just going to go get in the ring, get their brains beat out, and collect a check.
Yeah.
In a health sort of way, that is an unhealthy way to try to make money. So I think as a commission, we've got to identify people that don't, and we have the ability to say, hey, you're at health risk based on you're not very good. And whether that's because you're not very good or because you've got a medical impairment, what have you. But I think we have the ability and the right to that guy, and you guys know better than I, but I'm guessing there's guys that say, hey, I'll go get my brains beat out for three rounds and then call it a paycheck.
Yeah. There's not that much money. That's the sad thing sometimes. Okay. Just moving on. The other thing I just wanted to briefly discuss, guess it was, how long ago did we do the coax?
October 2014, so almost 18 months now.
So most everybody in the room
Over 18 months.
is aware of the fact that we've added PT, INR, and PTT platelet count to our pre-participation screening. That only has to be done on a one-time basis. We've been tweaking the protocol to the extent where if someone has an elevated PT but a normal INR, we would allow them to compete without having to get a hematology consult. If someone has an elevated PTT, I've been sending them for hematology consults. Doesn't happen that often, but maybe we've had 3 or 4 cases of elevated PTT. I think it's been twice we picked up factor deficiencies. I can't remember which factor it was. But the point I guess I'm getting at is that the majority of the time, when we do get a hematology consult, they've been coming back, they've been cleared. I'm not sure if there's any other way to tweak it anymore. I just wanted to put that out there. Anyone have any thoughts about?
I mean, can I speak from the layman that doesn't know much about the medicine part of it? Yeah, first off, I know you're doing the once in a lifetime because essentially it shouldn't change too often, correct? What we're seeing, or what I think we're seeing, is as boxers are getting deeper into their training camp, losing more and more weight, those are the boxers we're finding need to go for these hematology consults. As they get closer to the weigh-in, more of them have been likely to fail or require the consult. Afterwards, when they're hydrated, if they go after a weigh-in or if they go after a fight for a follow-up, they level off, it seems, and they end up being cleared. So from my standpoint, does the once in a lifetime or does it once, at one time and never again make sense? And the other is if these people are all being cleared despite having abnormal levels, can the levels be altered? Because it's not easy to get hematology consults, and especially when it's usually last minute that these guys are going for it. So it's just a matter of trying to see how we can make this a little more efficient moving forward for the fighters, not having to scramble when they get into New York a day or two before a weigh-in to get this testing done. So that's where this is all coming from, I think, because we asked Barry to look into this.
Do you have a go-to hematology list?
We have one individual down here who's willing to see boxers on relatively short notice at a relatively affordable price. And we've been looking for people in the Albany, Rochester area. Haven't found many that are willing to do it at the price range we currently pay.
So one thing, I think that it could be debatable the utility of doing the testing at all. So to do it more than once, I think is probably not worthwhile. If someone has some type of hereditary coagulopathy, bleeding disorder, that's probably going to stay with them no matter when you test them. So you'll pick that up.
I mean, can a criteria be the number of fights a person has? So if you have a guy who's 30-2 that may have an abnormal level, the fact that that person has 32 fights, maybe there's really nothing.
Yeah, I don't think many physicians would want to sign off on that. If someone has a abnormal lab, and it wouldn't matter to me how many fights this person has. If there's an abnormal lab that can increase his risk of bleeding, I would be concerned about letting this boxer compete without clearance.
So Eric, what you're describing is, so if somebody's been boxing outside of New York, state of New York,
Right.
They come here, they're not required in every state to get this done.
Right.
We require it, and then it's a mad dash to get it done, even if this is somebody that's had 50 bouts in their past.
Exactly, and
they're saying,
in New York, where we have a doctor on every other block, we have 20 doctors in every other block, and we can only really find one hematologist willing to work with us. It's probably harder if you're dealing with a fighter from Oklahoma or another state where there aren't as many practicing physicians. And basically, like you said, it's a mad dash by the time they show up to New York to see this hematologist.
It seems like that could be set up in advance.
So that's
right?
what I was wondering is, can we require this like a month in advance?
They can get the labs done wherever they live, and then on the even see hematologists near where they live if they'd be willing to take the fee. I don't think we have to have a New York hematologist.
Exactly.
Yeah,
I mean,
sure.
they could. Yeah.
As long as we have a hematologist signing off saying that this lab is okay.
Right.
That's
But the issue has always
criteria we
been
want, right?
finding one to see them on short notice. Most places, whether it's a hematologist, an endocrinologist, or even a neuropsychologist outside of the state, we've had people tell us there's an 18 to 24 month wait to get appointments sometimes. So that's, again, the concern is we can do the blood work, and we encourage the promoters to do the blood work, as far in advance as possible. Sometimes you have guys that take the fight within 2 weeks' notice. Not everything is planned out, months ahead of time.
Yeah, what's the shortest notice?
Oh,
We've had people take the fight on the day of a weigh-in. Guy was scheduled to fight in Pennsylvania. His opponent didn't show up. Guy was all medically tested from a previous fight in New York. Jumped on a train, came here that night, and weighed in.
yeah. So, but for the most part, I hope we discourage that. I really don't think that's a good practice. Having these guys last minute fill-ins. Medically, I don't think it's the safest thing.
Well, if they're approved to fight in another state and they have all their medicals completed, it's...
Yeah, sometimes you don't know if they've really been training or not.
What about online physician resources? There was one that was out of California. I got a bunch of emails about it like a year ago. It was like Second Opinion. Did you guys get these? It's like sign up to be a second opinion physician. It was like you would be given records to review. Really, what a hematologist doesn't really even need to see the patient that much. Sometimes they can just take a slide, right?
Mm-hmm.
Maybe just a basic,
So
labs.
yeah, I don't have a problem with the way things are now, especially if we get them to have to send the labs in well in advance.
Yeah.
And we haven't had that many that require consults lately. If it's really borderline, sometimes we repeat the test and it comes back normal. Then it's a non-issue.
And the issue, I would think it would become less and less of an issue as time passes because those who have had 50 bouts will have fought in New York already.
Yeah, listen, there's a lot less now than there were in
Right.
October 2014.
Sure.
But
Yeah. But initially when we first started doing this, we were getting hematology consults on almost 40% of the boxes, it seemed like.
Mm-hmm.
When we tweaked the protocol. And
yeah, it's
works much
definitely
better now.
decreased.
I think it's a nutritional thing.
Yeah, that's what I think,
really
too.
it is. It's vitamin K deficiency.
Vitamin K.
So,
Yeah, it's not hydration, but vitamin K.
Yeah, I feel like.
Oh yeah, I don't know
they're
what
just eating meat or
but you
Fat soluble vitamins.
you see it more with the
Right.
fighters who are cutting weight and are further into training camp than the ones who are
Yeah.
a month or two out.
I think
So
they're just eating
What
meat,
was the reason
like
for the
Atkins
consult?
diet or something.
What abnormality?
I mean, usually it's elevated PTT
If
or
right
elevated
now, I'll
PT
send
and
them-
INR,
If it's
right?
a PTT, rarely if it's low platelets. I mean, if I have somebody that's borderline platelets, 130, I had one today I looked at, about 137,000 platelets, I let them go.
It's okay.
If someone has an elevated PTT alone, I'll send them. And if they have a elevated PT and an elevated INR, I'll send them. But if they have an elevated PT and a normal INR, I don't send them. And that's cut down on a lot of hematology consults by that policy.
I wonder if they have an elevated PT and an INR, can you just ask them what they've been eating, and if not, tell them to eat like salads and stuff for a week, and then
Yeah,
check.
but I mean, these guys, they just some of them come in the day before the weigh-in. You don't really have that kind of access to them. It's not like a team sport where you with this team, 7 days a week. An athlete 7 days a week. You can advise them. Okay, so I just wanted to bring that up. The other thing is just a couple other minor things I wanted to bring up. One of the issues that came up today during our commission meeting. There's been this rule, I'm not sure if it's still in the books or not. There used to be this rule that boxers shouldn't box with facial hair. To this day, I'm not certain what the medical reason for that would be. I don't have any strong opinions about. I don't have any strong feelings against a boxer having facial hair getting into the ring. Does anyone here know of any medical reason why someone needs to be clean shaven?
Have to do with braiding the other boxer or something?
I mean, that would be more of an issue in mixed martial arts than it is in boxing, I would think.
Because I think it would hide like the last.
I know, but what I was led to believe was that if someone had a laceration, it's easy to deal with it if they have facial hair, but not could always shave. Any thoughts, anyone? So no one has any strong
Patty?
feelings against.
Patty, the beard out to.
So I guess this, so as I said earlier today.
James Harden.
No matter.
Yeah.
Yeah, so.
Now, unless it's a James Harden beard that comes out about this big.
Yankees rule.
Be a way,
Yeah, that's what it is.
way of keeping the opponent away.
I need medical reason.
What do other states do?
That's a good question. I don't know.
They don't really have any kind of rule or ruling as far as bids are concerned. But we're noticing more and more that guys are coming in with bids. As long as we tell them that they have to be trimmed neatly, then they kind of comply.
Yeah, but I remember when I first started coming around, they would make people shave before they got into the ring.
Back in the day, you
Back in
had
the
to be
day.
clean
Yeah.
shaven. Now, everything has changed.
Yeah, from a medical standpoint, so if somebody said, why are we doing that from a medical standpoint, I don't know if we got a comment.
Well, hasn't even the attitude for shaving electric versus straight razor, hasn't that also swayed in the surgical field, right? I mean, aren't there differential risks for skin breakdown and surgery?
Like a buzzer.
Right.
Yeah, not straight shave.
Right.
Yeah.
I didn't know that.
Yeah.
Okay, I guess that's about it in terms of issues I wanted to bring up. Another topic, just briefly, nothing to vote on, but it's something to think about that I think we will be discussing sometime in the future. As you know, mixed martial arts is down the line, and so there's been some rule changes in accordance with that. And one of the things that have changed is that there's no mandatory suspensions, no mandatory medical suspensions. And this is something I think we need to address as a medical advisory board. I agree that the previous rules had, if a boxer lost by TKO or TKO, they were automatically suspended 45 days. And if it was a KO, it was 90 days. And sometimes if someone was KO'd because of a body shot, they would still be out 90 days. I agree that I think that 45 days and 90 days are too long. However, my concern of not having a mandatory suspension for a boxer who has sustained a TKO or KO from head blows or sustained significant number of head blows during a boxing competition, not to have a mandatory rest period, I think is problematic simply from the standpoint is that this is not a team sport, it's an individual sport. And if someone loses by TKO and KO and you don't have a mandatory suspension, it's possible they can fall through the cracks. Even if you just say, okay, I want you to see a neurologist before we allow you to go back. Say if someone really is beaten badly tonight and then sees a neurologist tomorrow, and the neurologist, maybe not being familiar with boxing or with sports concussion, clears them, and this kid boxes in 3 more days and gets hurt. Those are the kind of things I want to avoid. And that's why what I will push for, and we can have a discussion, is that there be a 30-day mandatory suspension. And the reason why I picked 30 days is it's not that this is sort of an arbitrary time period. It's just that 90% of concussions resolve in 4 weeks, 28 days, 30 days, however you want to say it. So there's a medical reason for using 30 days. The 90% of all athletes who have a concussion will be cleared by that time.
Symptomatically, at least.
Yeah.
I mean, some of the fMRI studies are suggesting, that we're probably returning some of these athletes maybe prematurely when we're doing a 1 or 2 week protocol. But that's not ready for prime. The challenge is it's just not ready for prime time yet, right? It's all research protocol. It's not clinical.
So that's something that I want you people think, the board to think about.
Mm-hmm.
So you're saying MMA has no standard right now for how?
Well, this is New York State right now.
Right.
There's no mandatory suspension right now when the new rules take effect.
Other states have them or no?
Yeah. It all varies from state to state.
And
Some states even have a mandatory suspension if you box. Some people, even if you compete, they don't allow you to compete within a certain time period.
And if you're suspended in one state, that's universal.
Yeah.
That carries over.
Nationally.
Yes.
I mean, so you're saying a boxer who gets a TKO or a KO is out for 45 or 90 days. They cannot box in New York State for that
They
stipulation.
can't box anywhere.
But when MMA comes online, you're saying that they could do another MMA fight the following day.
Well,
based upon
the
current-
boxers too. I mean, well, maybe Jim can.
Yeah, just like so because of the new law, there's a new law that'll be in effect September 1st, legalized MMA. This comes out. What that did was change the statutory framework. So there's a new law that governs boxing, combative sports, including MMA, and that sort of in broad brush strokes gives very broad authority to the commission, but it doesn't prescribe a mandatory suspension period anymore. That was in the law that it's repealing. So what we're doing right now is building the rules and regulations, which might and which could have room for all these things. In the process of building it, we haven't had the opportunity yet to fully brief and talk with Dr. Jordan about his thoughts to go into the rulemaking package, which is being developed over the course of the summer, and would also presumably come, to your attention at some point in the next month or two. So I think, this discussion's an important and good one, but I don't want to put the cart before the horse and give the impression that there aren't going to be fail-safes, because what we have now is a new statute that is a lot shorter, literally shorter than the old one, because it paints sort of with a broad brush, gives broad authority, and leaves to the regulations the details. So we're working on that. So I don't think it's appropriate to give a characterization that
the statute is shorter. Shorter in duration?
No. I mean, the actual law is shorter in the number of words used.
Okay.
Because the regulations
it's not
will
robust.
fill in the gap. Yeah. It's broader. It covers a wider range of activities. It gives still full authority. No authority of any physician is curtailed in any way. But what it says is it doesn't, like the old law went into detail about prescribing mandatory suspension period 45 days. This says, a physician has authority to suspend in their clinical opinion for any period of days, but regs still can say that there will be what Dr. Jordan's getting at is suspensions in these cases where a physician notes head trauma and a TKO, or where there's a TKO and a KO. So we're developing that. And it's not necessarily going to be a departure from past standards. We just haven't had the opportunity to sit down and talk.
So will we have the ability is the advisory board to advise?
The ability, yeah. That's
so in the end, if we say 30 days, then that gets included in the statute, or?
Well, not in the statute. The statute's been passed. It's for our regulations.
So the statute refers to the regulations, then that's what we get to advise.
Yeah, the law sets these broad standards and powers of the commission, of physicians, the licenses that need to be issued, and then through regulation, the commission fills in the more detailed rules.
Okay.
And that's where,
that's what's being worked on by legal counsel.
This body does what it does in providing advice, recommendation, having discussions on an issue like this that sort of provide the expertise and intelligence that goes into, along with someone like Dr. Jordan who's on staff, or other opinions that you get through public comments or through ringside physicians, the opinions that fuel the product that comes out in the regulations. But in no way, I just don't want an impression that if a treating physician or an assessing physician at ringside saw a boxer who had a KO, and they thought that they presented with certain risks, or they thought just because of the nature of the knockout something was happening, they don't have the authority under this law to do a 90-day suspension, because they do. And nobody's trying to curtail that. It's I think this question is about, what's the best possible language for prescribing a mandatory suspension period?
Yeah.
And that's an important discussion as we develop the regs. I haven't gotten to have that.
The way I envision this, it's a mandatory minimum.
Right.
What you're proposing is we need to consider, are we going to say, is there a minimum day, period, suspension, if you get a TKO?
Yeah, if from head below.
No matter what the neurologist on the corner says.
Well, the reason why I was thinking about the mandatory suspension period is just as a fail-safe to prevent some of these guys from falling through the cracks. Because
or getting bad advice.
Yeah, and that would happen. I mean, a lot of neurologists aren't really familiar with sports medicine. They aren't, and the advice that different neurologists give to athletes that have sustained concussions is quite variable.
Is there an anticipation that there may be athletes who compete across various sports, like an MMA fighter may fight in a boxing match and vice versa?
That happens right now.
Because if you have two standards about a KO in one sport and a KO in another sport, and you have a fighter playing in both sports.
Well, I'm assuming that the standard wouldn't be too different depending on what you guys advise.
Yeah, the anticipation of the standard would be very similar.
I would think so, yeah.
And that if you're suspended medically as a boxer, that would carry over to any combative sport that you would be participating in.
And this could also be implemented through policy, right? As opposed to, is there a difference between policy and a regulation?
Yeah, well, for instance, let's say a regulation has the force of law. It's just another, it's law made by an agency that has jurisdiction over a thing. So if a regulation said mandatory suspension period in the case of a KO, 90 days, then no matter what, you're going to have to give at least, or minimum 90 days. You're issuing 90 days or 90 days plus, depending on the clinical assessment at Ringside. If there's a policy, which would be advisory, let's say, so you say, well, we should have a policy recommended by the medical advisory board and put in place by Dr. Barry Brooks, supervising physician of the Ringsides, that says, look, here's our policy. Because of the risk presented by a KO, we believe a minimum of 60 days is necessary in any KO, supplemented by whatever your clinical assessment says. If the need is greater, then that's what we'll do. And that would be a policy. So it wouldn't be it wouldn't necessarily be in reg, but it would be a medical policy, just like a Ringside protocol, a sort of policy, where you're giving instructions, people are expected to follow it, and they really should be following. You're at risk for not following the policy. But it's not sort of the force of law saying in all cases it's this, and it's the way you can change it too. A policy can change more rapidly and with less formal process than a regulation.
So it'll be more flexibility.
Yeah.
Doing it as a policy. Okay, that's good. All right, that's all I had to discuss. Anything else anybody else want to bring up? Okay, motion to adjourn.
Yes.
Okay,
Second.
Yes. All in favor?
Thank you.
Yeah.